Okay.
Well, good morning from Australia, Dr. Catherine Craven. Thank you very much and welcome into the Center of Digital Innovation of Latin America, together with our director, Nicolas Ketede, is actually working in the back end of things. Therefore, it would be fantastic if you tell us who you are and where you're calling from. And obviously, this is focused in Chile because we got the center right in Temuco. Therefore, please tell us who you are because this is all being recorded for the community in Chile, Temuco, and every other regions.
Fantastic. Well, thank you, Dr. Carol Hullin. Um, I am Dr. Catherine Craven. I am a senior clinical research informaticist at Mount Sinai Health System in New York City. I'm actually calling in from my home in Peekskill, New York, which is just up the Hudson River, about 35 miles from the city. So it's part of Westchester County, which is the suburbs of New York City. And of course, I've been doing a lot of remote working because of the COVID-19 virus, as has everyone else around the world. And I do a combination of operations and research surrounding clinical informatics, which is kind of more the front end, electronic health record and other HIT systems, including patient portals facing providers, clinicians, and patients, and also some back-end work, which we refer to as clinical research informatics, which has more to do with the research IT infrastructure, the data coming out of the HIT systems or ICT systems, as the rest of the world refers to them as, for research purposes, secondary research and operations purposes. And I have quite a number of experiences regarding both operations in terms of implementing functionalities and systems, as well as doing research surrounding them. So that's who I am. And I would like to say that I have been to Chile a number of times now, and what a fantastic place. I love it there, and honestly, it reminds me very much in many ways of the United States of America in the best senses. And so I feel a connection. I feel a connection with you, and I have a strong sense of support for what you're trying to do through this particular initiative and effort. So thank you, Nicholas Ketterer and Dr. Hullin, for inviting me to speak with you this evening. It's evening here in New York. And it's this, by the way, I don't know if people even would have reason to pay attention to this, but the East Coast of the United States and Santiago de Chile are at the same time at this particular juncture, depending on whether we're on daylight savings or not. But right now, it's the same time in Santiago de Chile as it is in New York City in the United States. So thank you. I appreciate being here.
Fantastic, because we are, no doubt about it, in Australia. We're in Saturday at 8 o'clock a.m. And therefore, I'm just so pleased. I get very emotional listening to you because I love to learn from the science you do, clinical informatics. We will talk about electronic health record. We will talk about some of the back end and research activities we do as a specialist in health informatics. Therefore, can I ask you, just for people to give some context, how things are going in your part of the world with COVID-19? Tell us a little bit the reality. I mean, this is the common people. Are you allowed to go and buy bread, or what happening over there? Because people think in Chile, it's only them living this. In Australia, we're having very, very extreme restrictions. Therefore, I'd love to hear your side of the world, what is happening.
Well, absolutely. Thank you. The United States is a very large geographic area, and what's happening depends on what region you're in. In New York City and New York State, but particularly the greater metro region surrounding New York City, the eastern part, or I should say the western part of Long Island, northern New Jersey, Westchester County, which is the county just to the north of New York City where I live, which is suburbs, but it's a very long, large county. And also parts of Connecticut and Pennsylvania. We were the first epicenter in the United States, and we were hit extremely hard, extremely fast. we had thousands of cases in the city alone. And my health system, the Mount Sinai health system in the city, was in many ways the epicenter of the epicenter at first. And we are now at a very low level of cases overall in New York State. Yes, thank you. It's wonderful. We are being extremely cautious, however, in this greater metro region surrounding New York City because we have such high population density. And so many of us rely on public transportation to commute in. And so many people also live in very tight, particularly in the city, but even further extended out, live in very tight quarters. Not unlike large cities everywhere, including Santiago and some of the areas outward from Santiago. The more contact you have, the more likely you are to spread this virus, which transmits very easily, much more easily even than the flu. And we know how quickly we pass around colds and influenza during, the cold and influenza season, particularly fall and winter. So we're being very, very careful. And the restrictions have slowly lifted in a phased way here in New York State. New York City and this region, however, is very cautiously approaching further reopening. We're not under lockdown, but we are, in terms of, we don't have to stay home. More workers are allowed to go in and commute into the city to work. But if you want to know the reality, many workplaces are encouraging all workers who can work remotely. And, certainly there are many jobs where you cannot. You must be on site. If you're an essential worker that works in a grocery store or works in a hospital or clinical practice, if you do certain functions that are absolutely, mandatory for society to run, you have to show up in person. That's necessary. But for any sort of office worker or information technology worker or informatics person, researchers, all manner of work that can be done from a distance remotely, most companies are really encouraging workers to continue to work from home because we need to see what happens as we enter school, as the public schools, as the K through 12 and as the universities go towards fall classes. We need to see what happens. And so we want to therefore very cautiously allow only the people that must be at work to use the public transportation and to come together in the city. Also, at this juncture, the plan is to have New York City school students go to school in person, but there's a lot of controversy surrounding this. And a lot of teachers and staff and people in the know, frankly, expect that to not work. And so I'll take a pause here. But before I take the pause, I do want to say what's going on in the United States very much depends on the region. We have calmed the infection rate down. And yet at the same time, in my own little community, we have more cases in my community, my little city of 30,000, actually under 30,000, closer to 23,000. We have more cases in our little community than many counties, entire areas, large areas, regions in other parts of the United States. So what's going on in the United States depends very much on, what state, what city, what region you live in. But I've just kind of given you a snapshot of the very cautious approach that we're taking in the greater New York City area. In addition to moving into school opening, we're also moving into the fall cold and flu season. And, we do not want to have a massive second wave of COVID infections crossing over with infections and transmission of cold viruses and influenza. So let me take a pause and let's see if you have any comments or reactions.
That's fascinating. You say that, Catherine, because the nurse Luis Vergara Fernandez, who's actually contacting us from the actually fifth region of Chile, Valparaiso. I don't know if you remember, near the water, near the
Yes, I
ocean. It
do.
was
A
Valparaiso.
beautiful
He
area.
That's right. That's right. You remember very well. Therefore, he asked exactly. The region is asking the same question as you say. Do we send the children and young people to the schools and high school and universities? Therefore, do you know any scientific evidence about this? I mean, is this a myth or is it what? What is happening with that decision makers? Because some say yes, some say no, but in reality, what COVID-19 can cause us if we're not careful with this approach?
Well, first, I want to say that, in very rural areas where there are not many cases, and where there is not high population density, like there is in cities where you live right close together in large apartment buildings or right next to each other and take public transportation, it may be possible to open schools safely, particularly where the population of the school is small and it's easier to maintain social distancing. Windows can be open. The school administrators and teachers can control the fact that students are wearing masks easier because there aren't huge numbers of students trying to roam through hallways. So in certain rural areas, the best knowledge and this isn't just not Catherine's opinion, this is not my opinion, this is the opinion of Dr. Fauci, our top epidemiology and infectious disease expert in the United States, as well as every other epidemiologist, every other medical scientist, all of my colleagues who are in informatics and who are, aware of the facts and aware of basic epidemiology, understand that in certain areas, it may be possible to do some in-person and or hybrid. However, the vast majority of scientists are firmly against this idea of opening in person, at least for the fall. And the reason is, at least in the United States, is we did not do a good job of uniformly shutting down and locking down. And so therefore, even though we locked down very hard in New York City, in New York State, and in the Northeast region, we did not do a good job, and the virus has spread almost unchecked, particularly in the south of our country and in the Southwest. And the reality is, every time groups come together, this virus spreads. And we do know that although when you are above age 50, you are more likely to become very ill with this. But the fact of the matter is the data are now in, and we do know that children, single-digit children, young children, are very much spreaders of this virus. Now, young children and teenagers and people in, their 20s and 30s absolutely can become very ill with this virus and die. When the numbers are in, we know that this can happen. They are less likely to. However, there is some evidence that they may actually even spread it even more than older people. They may carry higher levels of the virus. The science is not completely in on whether they carry and spread more, but the fact of the matter is children in kindergarten through certainly elementary school, middle school or junior high school are very much carriers, absolutely as much as teenagers and young adults. They can carry the virus. And one of the things that's so difficult about this virus is that not only does it spread at about twice the rate, the transmission rate is about twice as likely to happen as influenza, and let's think about how easily we share that and how sick we get every year, and how unfortunate that is. Not only is it about twice as likely to transmit, the fact is that with this virus, everyone can carry it and spread it, and it spreads. There are two things that go on. You can be pre-symptomatic, which means you're not exhibiting symptoms yet, but eventually you do. as your course of having this COVID-19 virus unfolds. So you're pre-symptomatic. At that point, you are the term is shedding the virus. You're transmitting it. The other thing that is so scary, and the numbers are not completely concrete, we don't fully know, but somewhere between 40 and 60% of all cases, including those school children, those young school children, are carrying the virus and spreading it, but they're asymptomatic. That means no symptoms, and they never do fully develop the virus, or if they do, it's a very mild case. They may not even know they have it. And yet, when you're asymptomatic, you're also shedding this virus and spreading it. And so that's the science. That is the science. That is the data. And that is why you will hear from, scientists and medical experts a lot of concern about opening schools. It's not, we all support, we love school. We want school. No one wants this virus. We don't want this. It's not, don't let some sort of politicized message be that people who have concerns are anti-school. That's not it at all. It's that we're anti-spread of this virus because it's deadly to many people. And one other thing I want to say is it's not as deadly or does not cause as many young children to be sick. But there is a certain population of young children, including infants and babies, who have become very ill and died. And nobody wants to see that. We certainly don't want that. And then another a piece of this is that we're starting to see that for quite a number, and I don't have a specific number. I don't think we have a specific number yet, but a large number of adults who come down with this virus, there are long-term effects, long-term multi-systemic, multi-organ damage, particularly the lungs and the heart, but other organs as well, including the brain. There are neuro effects. And it's taking some people very long to recover, even if they get through their initial acute course of this illness. It's taking a long time to recover. And this is the concern. We do not really fully one of the many concerns, we do not fully understand the potential long-term effects in children and in what age group or what physiologic or genetic makeup. We don't know this. But there are certainly some cases in children where they are having some demonstration of long-term effects too. And clearly, the last thing that we want to do in our children is to create a chronic health condition, damage that the body cannot repair and that causes long-term damage, quality of life issues, functionality issues. Those are the most important things. In addition to, certainly we don't want deaths, but we don't want spread of the illness, and we do not want long-term effects. And that goes across the entire population. So this is from scientists. This is not, Dr. Catherine Craven's opinion. This is from all of the top scientists in the world. And a last comment, and then I'll pause for comments. But there are certain political powers, including the ones that are in charge of our administration, in the White House right now, who their top priority is the economy and getting reelected. And this, they're unfortunately, certainly not everyone who is in elected office is, by no means is everyone an unethical person or corrupt. But we have far too many people who are trying to mute the voices of science because of political or personal gain, economic gain. And this is not the ethical way forward. And this is not what science supports. And so please do not listen to any politicization of the message. Pay attention to the scientists because they're not wrong and they're not being alarmist. They're saying this is a virus we've never seen before and it has effects. They also know how we can get out of this, but the way out of it is not to pretend it doesn't exist and go about business as usual. So now I will pause and let you reflect or react about what I've said.
Therefore, you have identified, Catherine, the gap between the complex reality of science and the evidence of caring for COVID-19, and also the unknown, recognizing the need of taking this with a lot of um, risk prevention.
Yes.
Therefore, because we're very far away, we see in a lot of television, a lot of political
Mm,
election. But
yeah.
when we talk about numbers, and obviously with a lot of respect to your scientific background, but it looked like the grandchildren cannot visit the grandparents. They have to avoid that. Uh, there's certain practical terms based on evidence. Then you must wash your hands. Why do you need to wash your hands? I mean, I'm talking about bringing down the science. That we're very aware of this for decades. I mean,
Mhm.
especially when it happened, the cholera, the influenza. I mean, we have history globally about all this type of pandemic approach to resolve with digital technology. Therefore, in that sense, what would you say for a family who are very with a lot of fear of the unknown?
Mhm.
Um, if we get the mother of three children, I personally wouldn't send them to school yet. But
Mhm.
tell us why, in practical terms, why do you have to be taking care of yourself right now in self-caring?
Absolutely, that's a fantastic next shift of the discussion to the pragmatic level. First, we know that the virus, all viruses, not just this one, this is a new virus and we're learning more and more about it, but all viruses are transmitted when you get the virus on your hands and when you touch surfaces and then other people touch that surface and then they touch, they rub their nose, maybe they rub their eyes, they cough, put their fingers in their mouth, particularly if they're children. And then that's how the body takes in the virus and you become sick. Another way of spreading viruses, and this is very virus dependent, but very much so with colds. If you cough or sneeze, or you talk and exhale a lot of air, the virus goes with that exhalation. It's very minute. It's called aerosolization. And when we say aerosolization, we don't mean the virus flies like a bee from county to county or province to province. That's not what we mean. We don't mean that it shoots out like a gun. What we mean is if you breathe or you cough or you laugh or you sing or you shout, you expel air, with force out of your lungs, out of your nose, out of your mouth, and the virus goes with it. And I mean, we already know, and we all know that, if you're standing next to someone, even if you don't touch them and they're really sick and they cough all over you, we know this is a terrible idea because you're going to get sick. And the coronavirus, the group of coronaviruses includes the common cold. This is a coronavirus. It just happens to be a more severe virus with more severe effects and more easily transmissible than the common cold. And so we need to take at least the same precautions that we would with any other sort of virus. There's nothing, magical about this one. But there was very early confusion about does it aerosolize, and this frankly this was confusing to a lot of scientists and medical personnel, because we're like, well, of course it does, because it's a coronavirus. This is not something that's truly unique. It is a novel, a new virus, but it's within the same sort of family. And so this is the reason, and this is the kinds of steps that you can take to lower your risk. The only way to have no risk at all is to stay at home and don't visit anyone outside of your home, and don't leave your yard or your front porch, your patio. Don't leave your property, and don't interact with anyone. And we know that that's not practical for most people. But the way to protect yourself then is to socially distance. And when people say, 6 feet, that's in the United States, we're very backwards, and we still use the system of feet and inches and yards. Essentially, if you're less than a couple meters away from each other, the same common sense that you would use if someone has a cold. If they're sick with a cold, or even if they might have a cold and they're not feeling sick yet, but they've been exposed to someone who does have that cold, you keep your distance, because you don't want to touch them, because their body, their hands in particular, but the nose, their mouth, they have that virus. And so the same with this one, you keep your distance, because you don't want to get coughed on, you don't want to get breathed on, and breath, the louder you are, and the more time you spend together in close contact, a few feet, less than a meter, only a meter, keep your distance. You can visit with your grandparent, and I mean, we all love to hug each other and kiss each other, but you know what, if somebody's sick, keep your distance. Stay several meters apart. Just stay apart. Sit on the porch together, visit outside, but stay apart. Don't touch each other. And you can have wonderful interactions and catch up. And then eventually, when we get through this pandemic, you can kiss and hug again, as I know Chileans love to do.
That's exactly right, Catherine. It's a change of culture. What are we going to do? Because you love, I mean, when you visit a few times Chile, the culture is to hug, is to have a little bit of vino tinto, a little bit of red wine, have a little bit barbecue. But now how do you think is the role of education using digital innovation? How we can educate the communities about this? How do you see that?
Well, I totally understand. And, Americans in general, but particularly those of us of Northern European descent, we're sort of known as English or British or German, and we don't touch. Well, over time, we've become quite a hugging culture too. And we're used to a lot of contact, and frankly, it's quite wonderful. It's a way to bring people closer together, whether you're family or friends or colleagues. It's a way to immediately establish, I'm not a threat. I care about you. Let me feel your energy. Let me touch you. Let me hug you. Let me give you a kiss on the cheek. It's lovely. It's wonderful, and I so admire this about Chilean culture. But what we do in a pandemic is the most important thing is if we care about each other, if we value each other, if we love each other, even if we just know each other is necessary and we don't really like each other personally, we do not do anything that spreads that virus. And hugging, close contact, the cheek kisses, shaking hands even, which is a very, American culture. You shake the hand in business. We can't do these things. But, we have to realize we're not saying we can't do these things forever. We're saying we can't do these things now. We can't do these things probably for the next 6 months to a year or so until we have a very safe vaccine. And honestly, we will get through this. We've been through pandemics before. There was a pandemic in 1918, which actually was it was an influenza, terrible influenza, related to, but not the same thing as the coronavirus family of viruses. It was there were 50 million people or more died around the globe. We don't want that many deaths. We already have too many deaths from this. And so it's a small sacrifice, a small inconvenience now for us to maintain that socially distance, to not touch outside, not touch each other in any way outside of the people who live in the same household. And then another thing that has proven extremely effective, and this is not new science either, by the way, and the Chinese and other Asian countries are very good about this because they do tend to live in high density population cities where there's a lot of closeness of breathing the same air and being in contact on public transportation, is when you are outside of your home, wear a mask. It does not need to be a surgical mask. It does not need to be a designation known as an N95, which healthcare workers wear when they're inside the hospital and there's an infectious situation. But it needs to be a double-layered cloth mask, and you must wear it over both your nose and your mouth. And so it's both when you're outside of your home and your yard, You socially distance. So stay as far apart as you can and still hear each other to talk, because that's the farther apart you are, the safer you are. And also wear that mask when you're in public. And keep in mind that when you are outside with the air blowing and the breeze and the big open, there's less chance of the virus hitting each other, but you still want to wear that mask and be distanced, because science data shows that you're protecting the other person. If you are exhaling the virus, any virus thing inside that mask, and they're doing the same for you. It's a courtesy. Think of it as a courtesy. I mean, when no one wants to walk around forever wearing a mask or not hugging. We're not asking anyone to do that. We're saying for now, as we get through the pandemic, short term, I don't, Carola, do you want to be responsible for somebody else's severe illness or long-term debilitation or death?
Not at all. That's why I think self-caring, being responsible, never before. I think we have to be in a collective thinking, and always. Now, since we've been so pragmatic, someone at home, what is the pragmatic approach to use evidence within a hospital? I know you're actually working with a very large healthcare institution. Therefore, do you think, because I've been a witness, I mean, my daughter is a nurse, and she's actually right at the front of all this epicenter. And therefore, what do you actually advise to those nurses, doctors? How do you bring this evidence? And it's so, when I listen to you, it's common sense. I know some politicians may not want to listen to this, but they don't understand the consequences, especially when you say, look, your children may have a chronic disease for the rest of their life. You can't. I mean, firstly, it's an extra challenge for the family. Then it becomes an extra challenge for that young person when they want to enter society to live with that. And thirdly, the mortality rate. I mean, we know people with chronic disease that died early. I mean, why would you want that for your children? Therefore, what would you say for the doctors and nurses and therapists that are on the front line? They add evidence. You must wear gloves. I mean, I've seen some, it's crazy. I mean, I know there's a lot of healthcare professionals, but they said, oh, I don't have any gloves. I said, well, don't get close to it. I mean, you cannot assume. You have to protect yourself too. What is the advice for them?
Well, the main thing is to, I've been to Chile, and I know that healthcare workers are highly trained. You have scientific training, you have medical training, you're professionals. This is, it's very impressive. And in any institution, sometimes it can be easy, however, to backslide against your best practices. And in this case, all healthcare professionals, regardless of your role, whether you work as staff manning a front desk, you're a clerk on a hospital ward, you're a registration person at the front desk in a primary care practice, you're a nurse, you're a physician, whatever your training is regarding hygiene and healthy practices, follow it to a T, follow it to the utmost of your training. Okay, that's the number one thing. Secondly, you have to realize that particularly in hospital settings, where COVID patients who are severely ill are admitted, these are some of the safest places in the world because hospitals have special heating and ventilation systems and filtering systems. They have so many protocols because they're used to working to not transmit viruses and infectious diseases. They're used to this. And do you know that the rate of transmission amongst healthcare workers is less than it is amongst the general population, because so many healthcare workers have, first of all, they always follow the protocols for hygiene regarding hand washing, hand sanitization, wearing gloves, changing gloves in between patients, washing hands or using sanitizer between patients, not touching your own face after, being in patient rooms, wearing gowns, changing gowns as you need to, changing the gloves as you need to, wearing the mask. These are all, this is nothing new. This is practice around the world, and I know it's practiced in Chile. And just go to the maximum level, revisit your training, and what are the top, the top steps you can take regarding hygiene and protective gear, and do that. Just do it and be really, really religious about it, because your life depends on it. And the fact that people, now, it's not that there's no risk. We know that healthcare workers are our heroes because they're always willing to take on more risk than the rest of the population to help us. And this is why we value them so much. They help us, they help our bodies help get better. But the fact is that, in the United States, and I know this is true elsewhere, healthcare workers are at less risk than the general population because of all of the facilities and all the procedures, protocols, and protective gear in place, and the training. And this is not to say that healthcare workers are immune. We've had more than 700 healthcare workers die in the United States as a result of this. Now, whether they caught it at work or caught it in the community, we don't know. And both are possible. In the Mount Sinai Health System alone, remember, we were in the epicenter of the epicenter, and we had hundreds and hundreds of cases. At one point, we had in the neighborhood of 2,000 cases that we were handling across our 8 hospitals and a field hospital tent set up in Central Park. In our health system alone, we had 26 healthcare workers, about a third physicians, a number of people who were other healthcare providers, and then about a third of that 26 people had non-clinician roles, and so surely they didn't catch it they didn't catch it from patients. They caught it in the community. But keep in mind, we have between 38,000 and 40,000 employees. And so although we had a memorial service online to honor, our fallen coworkers, it was incredibly moving and very sad, and we value them. And I don't want to minimize the fact that we lost 26. But we have
the superhero for me, yeah. Catherine, even just one is too much. Knowing that we can prevent it, and we can work as a community. In that sense, since we got only 10 minutes left, basically, Catherine, can you tell me, you mentioned in the beginning a few innovation. You talk about the use of electronic health record, but one thing that really bring my attention is the portal. Can you tell us how is using now the evidence to engage the patient? How do you actually do this? Then apparently you, in one moment, you use an instrument for the Spanish with your patients, no?
Oh, yes. Okay, absolutely.
Can you tell us about that innovation? Because in Chile, it's just a dream. I mean, we have a lot of people from IT. We have a lot of people from other, they speak French. We have people from Brazil, but it's unlikely you will have a system who actually provide other than just Spanish. Therefore, can you tell us about that digital innovation? Because I found it so fascinating.
Well, so, first of all, the technology is completely there to have what's called a patient portal. Well, patients have their individual account where they can look at their own health information, and that health information is funneled into their account, which is web-based, online. It's funneled from the electronic health record system, which is the computer-based system that nurses and physicians, pharmacists, other healthcare providers enter the data in. So when you go to visit, you go see your primary care doctor, your nurse practitioner, you see that person entering information into a computer. That's the electronic health record system. So it keeps all of your information in there. And then in the patient portal accounts, information from that, not all of it, because a lot of this is intended mainly for communication between your healthcare team and as a matter of record, but certain things like your test results, your screening, like if you have a mammogram or you have a colonoscopy to check to make sure you don't have colon cancer, these sorts of screenings, important screenings, prevention, lowering of risk, taking control of your own destiny, these sorts of information find their way into your patient record, in your patient portal account. And one of the things that's fantastic about Now, in the United States, the major electronic health record systems, in part because of some legislation that occurred called it was actually the High Tech Act, which was part of the American Recovery Act of 2009. But it stipulated that there must be accounts, patient accounts and patient portals. So therefore, all that was impetus, federal regulation, which we don't do a lot of surrounding this kind of thing, but we did surrounding ICT, but we did in this case, and therefore all the electronic health record system vendors then actually did, if they weren't already, they did create these patient portals that are connected with electronic health record systems. So it's completely technologically possible. And it's a fantastic way for patients to go in and check their own information, engage with it, take control of their health by looking at it. And one of the things that's so amazing about the possibility of most patients in the United States being able to, get a login for their own health record for, the primary care provider that they go to, or other specialists that they see within the health system that they go to, is that in this time where it is much better to not go places in person if you can avoid it. You have to go in person for certain healthcare treatments and visits, but you don't always have to go in person to get the information. You can go to this patient portal account and you can visit, well, what was your last A1C test for diabetes? What is your trend over the last, several months, 6 months or year? The last time that you did go in for your mammography, what were the results? If you have any condition in which the physician or other healthcare providers send you to have tests, you can look at the tests and you can see what the results are. And so you can use this portal not only to continue to help manage your own health, and then if you see something that you don't understand or you think is not what you understood from the last conversation you had, you can then via the portal account actually, in a sense, email or message your provider and communicate that way to get clarification. But in this COVID time, there's all kinds of communication and information sharing that can be done here in this kind of account so that you don't have to go in person unless you really do need to for some sort of physical treatment or physical examination. And so it's not solely having anything to do specifically with COVID-19, but the leveraging technology to help people be safer and minimize risk is always a good idea. And so we are finding between massive ramping up of telehealth visits. You can't do telehealth for everything. You can't do telehealth for certain cancer treatments, for surgeries, but you can do telehealth for a lot of visits. So between telehealth with patients and then the use of the patient portal and encouraging patients to engage that way, it's another way to help minimize risk of in-person visits and going indoors places where other people are probably sick. We don't want to do that. So it's a good idea, and it's a good idea long-term. It'll be a good idea long past the point where we've vanquished COVID and we have good vaccines and we're no longer in a pandemic. The pandemic isn't forever, but it will always be a good idea to have a patient portal account that is attached to your provider's electronic health record. So there we go.
And Catherine, just a technical part, just for the people who will review this interaction with you, you did put some of the patient portal with Spanish. Therefore, it was an automatic response, or it was someone behind. How, from the clinical informatic perspective, how did you get the semantics that way? If one of our students listened to this, how did you get through notes? It was a chat box. How was technically work that?
Well, a lot of times, the answer, even though in informatics we love technology and we love data, and this is super fun for us. The reality is a lot of times it's not about that. It's about people, and it's about helping people use the technology we already have. It's not about a new algorithm or some fancy new technology or something expensive or some outrageously expensive translation service. It was not about that. what this was about, we knew, okay, first of all, My Chart, which is the version of the patient portal that goes with the Epic electronic health record system. Epic is a major vendor. We knew that it was possible to get, they have an option where just the navigation pieces in the patient portal, which is called My Chart, it's possible to get that available in Spanish. We had not purchased that option yet. However, it is never going to be possible for the provider notes that they write in their own electronic health record, the physicians, the other clinicians, they will always be writing in the United States in English. And so the record from which data is pulled into My Chart, a lot of that data, those test results, a lot of information will always be in English. And on top of it, if you want to message back and forth using the My Chart function to send essentially like emails to your provider, which is fantastic to be able to contact directly and not have to go through the office and leave a message and wait for someone to call you back. That's not going to happen in Spanish, much less the dozens and dozens of other languages that are certainly used by patients that are in the Mount Sinai Health System in New York City. So what we knew was that, think about it. When you learn a second language, before you're really good at talking face-to-face and absorbing spoken language at you, you're actually pretty darn good at reading and comprehending. And then you can take your time. If it's written in an interface, you can look terms up in your own language. You can take that term and look it up in a translator that you're, to slowly take your time to absorb. And so our hypothesis when we created this Spanish language navigator program, our hypothesis was, hey, we can't totally change the interface and make all this information in Spanish. That's just not going to happen anytime ever, probably in the United States. However, our Spanish language preferred patients are very, very capable. And if we get them over the hurdle in their own language with someone who's bilingual to tell them how to sign up for My Chart, what My Chart is, we get them logged in, we show them around, we navigate them. So we show them, hey, this is the great stuff that's available here, the test results, all the different possibilities. Here's how you can message your provider. If we talk them through this in their own language, get them signed up. And then in terms of the specific functionality, Open Notes, that's a very particular function where the actual, medical notes for a progress note, the summary note of a visit with your physician or other provider, when they type up and say, this is the general situation, here was the diagnosis, here was the recommendations, here's what we're going to do for follow-up, and next time we talk, here's what we're going to look at. Those notes, a functionality is now possible for that note to appear in your record. How powerful is that, to see exactly what your physician wrote or your nurse practitioner wrote? That's amazing. And, there's a lot of concern by, particularly physicians, oh my gosh, people are not capable of understanding my medical language. Well, okay, not every word. But, whether you speak English as a first language or Spanish as a first language, you can take your time, you can walk through this, you can look up terms online that you don't understand the medical language, and in most cases, you can really quite easily understand what's going on. And so what we did was, when we navigated people into their patient portal account and then showed them where these, all the functionalities, but then showed them where these notes were available within the account. And then we had the navigator do a verbal translation of the note, like a recent note, and from an ambulatory provider, either the primary care physician or, a particular specialist that you see in the office, not inpatient in the hospital, but in the office, in their office. And then we had the navigator explain, why you would want to read this information. And the reason is to make sure that you understand what your health situation is and understand what the recommendations are by the doctor or the nurse practitioner. And also, if you see what you feel is a mistake or there's something you don't understand, that way then you can actually follow up quickly and communicate. It's a team. You're a team with your providers, and you are the one who's in charge of your health ultimately. And so this is about empowering you. And when we did this program, there were 555 Spanish language preferred patients who went through this program, but many of them included, like, my mother's in Florida, but I'm the one that logs into her account, and I want her to call. I'm going to call her so she can listen to this session. Or I'm the husband and I'm the best speaker of English in this family, but my wife and son are along because we all want to learn about this with the Spanish language navigator, so then we all understand how this works. And, as one of the wonderful things about the Chilean culture is you tend to be very family oriented, very community oriented. You network, you pass along information, and you help each other out. And this was a part of our hypothesis, is not only can Spanish language people do this once they are shown how and understand why, but they'll help each other out. And then, if you go back home and you have a family member or a trusted friend or someone who perhaps speaks English a little bit better than you, reads a little bit better, you can partner with them to log back in and go through that information on a regular basis and keep track of your own health information. And so this is what is possible, and this is what we want, because we're done with the days of sort of a patriarchal system where the physician or the healthcare provider tells you what to do and that's the end of it, and you don't think about it or know anything. We understand now that, of course, nurses, physicians, healthcare providers will always have expertise that you need to listen to carefully. And yes, there are many things you need to follow, but you are responsible as an individual and empowered as an individual to be a partner in managing your conditions, in getting better from acute injuries or illnesses. Why wouldn't you want to have a good, strong relationship and be as informed as possible about, how to care for your diabetes or your chronic obstructive pulmonary disease or whatever condition it is that you have? Why would you not want to know as much as you can in a very quick, frankly, quite easy way once you're shown how, so that you can stay on top of this stuff? And it doesn't mean that you're logging in every minute and doing nothing but obsessing about your health record. It means that you log in when you need to. You look at this stuff when you have to. Sometimes people that don't have much in the way of a chronic condition, they're not managing a lot of multi-system situations. Maybe they only log in a few times a year. They log in to see results after they go in for an annual exam or a screening, and then the rest of the time they don't use it. Fair enough. This is about making it work for you. If you have diabetes or you have some serious chronic condition where there are a lot of tests, there's a lot of results, and you really need to stay on top of what's going on, it's a tool for you to empower yourself. So that's what that's all about. And my idea was that, I know Spanish language preferred people, and I know people, and I know how smart they are, and I know that they're going to be very motivated people, and all they need is just a little help to get in and understand in their own language. And then from there, they can use every translator in the world, online translator to look up terms and figure it out. You don't have to, being smart is not about speaking English. I mean, good heavens, it's about having a little help to get past the initial barriers of use. And then from there, you take it yourselves. And one last thing, and this is, I think, something that people in Chile can access, is there's something called the National Library of Medicine, which is a National Institutes of Health agency in the United States, a government agency which is over all health research and services. And the National Library of Medicine is actually also a research agency that is sort of the seedbed of informatics too, in addition to medical librarianship. National Library of Medicine, in addition to having created PubMed, which is the world's largest and best citation index for looking up all of the different publications, scientific, medical, and bioscience publications. But National Library of Medicine created something called Medline Plus, medlineplus.gov, which is for consumers, it's for patients, it's for lay people, it's for regular people, and it's got a wealth of health information, and you can look up all kinds of terms, and guess what? There is the option where you can switch on Spanish language in that. And you can access that for free all over the entire world. If you have web access, it's medlineplus.gov. And of course, we directed our patients who went through the Spanish language program that yes, there are other authoritative, appropriate sources online like WebMD and many others where you can count on the information being correct. But most of them don't have Spanish language translation. And in this case, we can for sure vouch that if it's medlineplus.gov from, the National Institutes of Health in the United States, National Library of Medicine, not only is all the information in there correct, it's been vetted by the best experts in the world, but you can get it in Spanish right in that interface. So why wouldn't you use that? So hopefully this is some useful information for you going home. And even if, you don't have a patient portal account yourself at this point, someday you will. And hopefully, if you take some notes when you go to see your nurse or nurse practitioner or your physician, take some notes and then go back home. And if there's a term you're not sure about, look it up in medlineplus.gov. Take control of your own health. You can do it. I know you can. And in the meantime, be very, very safe for COVID. We can stop this, and we will. And I don't want to see one more tally of more people being sick anywhere in the world, or much less anybody dying. So let's do this thing together.
Thank you so much, Catherine. Therefore, thank you so much. And Nicolas, you can cut off the streaming. That way I can actually be offline with Catherine. Thank you so much, Catherine, for visiting CITLA.
Thank you. It's my privilege.
And basically, I have taken so many notes and have to reflect on all your suggestions and evidence, especially, as you finish the sentence, is today the time for us to take charge of our own health. And in that manner, we can really prevent a lot of things. Therefore, let's see if he put us offline. That way we can actually catch up a little bit, because I haven't seen you for maybe a month ago now.
Yeah, that's right.
A month ago.